Just a couple announcements, first of all. Our next two speakers will have about up to 40 minutes of speaking, and then we'll have up to 20 minutes of questions. We'll have two people circulating with microphones. If you have a question, please locate them, or they'll locate you, and speak in the microphone so we can hear the questions. Our first speaker we're very honored to hear from, Dr. Thomas Graboys. He's a clinical professor of medicine at Brigham and Women's Hospital and Harvard Medical School. He's the president emeritus at Lone Cardiovascular Research Foundation and attending cardiologist at Brigham and Women's Hospital. He's a graduate of Cornell and New York Medical College, and he completed his internal medicine training at Boston City Hospital, as well as a cardiovascular fellowship at Peter Bent at Brigham Hospital. He received, in 1999, the Harvard Medical School Humanism in Medicine Award. And then in 2008, he co-authored a book called Life in the Balance, a physician's memoir of life, love, and loss with Parkinson's disease and dementia. And Dr. Graboys will be also speaking today with his wife, Vicki. And then at 1 o'clock, he has a book signing. So encourage you all to attend that. So we'll turn the time over now to Dr. Graboys.
One of the major events that is occurring right now is for you to be able to hear me. And so two things happen when I give this talk. One is that individuals are having pauses. Which I'm sure all of you are familiar with. And in my situation, what happens is as I'm talking and we're going along, and all of a sudden everything goes chaotic for 2 seconds, 4 or 5 seconds. And so I just mention this to you so that when I've given this talk to non-physicians, they get kind of upset seeing me kind of get a little bit phased. The other thing that happens is that I may start off with my vocal in a particular tone, and then all of a sudden it dribbles down. No one can hear me. So I've had people in the audience who say, speak up, speak up. And so if I'm not being clear, please ask me to speak up. Vicki and I are delighted to have made the trip down from Boston yesterday, and we wanted to talk to you a bit about what's happened to me over a period of time as a actively practicing cardiologist for 35 years at the Brigham and Women's Hospital, and how that has affected not only myself but my family and my colleagues and people I work with. I did everything I could to deny that there was a problem going on, and we'll speak to that probably in just a bit. About a year ago, NPR, National NPR thing, asked me to do a section of the I Believe series that was on NPR for a number of years, and it was important because it did summarize, and I'd like to read that to you now. So this was on NPR, ran for quite a while actually. You may wonder why Vicki is here, other than the fact she's much better looking and much smarter than I am. but the emphasis is on the total picture, and there is no way that I could be here with you unless Vicki was here. She has had a profound effect on how I deal with my issue. So we start now. I am a physician who became a patient. I was diagnosed approximately 5 years ago with Parkinson's, a progressive neurological disease. I first noticed difficulty drawing blood from cardiac patients. I could no longer do any interventions. While this disease is not curable, it is manageable, and that's a major message I try to give to the patients that I've been seeing. Medications necessary to control symptoms are now readily available, but the medications are now only a part of an organized program which should include proper diet, vigorous exercise, and perhaps most importantly, psychological support from spouse and family. I can't emphasize enough how important family infrastructure is, and colleagues. But we could extrapolate that not only just with what we just said, but the fact is that everyone has a story. You could come down to the audience with a mic and say, "What's your story?" And no doubt, they're simply ask your neighbor, and not be surprised if they come forth with a host of issues, concerns and anxieties. I believe it is crucial to understand that we, as patients and caregivers, need to view chronic debilitating illnesses as a long journey with every right to be optimistic. I believe that hope is crucial to outcome, and that the loss of hope summons despair. To deal with the daily struggles, we need optimism. With the daily struggles, we need optimism and a large aliquot of humor. Can't go this road without having some sense of humor and have a sense of optimism. Perhaps the most universal element in dealing with chronic disease is the necessity of working with a physician who is capable of listening to the patient's story in an empathetic, unhurried manner. The key here is unhurried. We need to all be listeners. I believe that fear can become an invasive process that affects us all, and especially those with chronic disease. Being a Parkinson patient means the realizations and that the need for long-term care is particularly difficult pill to swallow. Dealing with a disease is a full-time, 24-hour affair. Let me repeat that. Dealing with a disease is a full-time, 24-hour affair. It strips us of our former identity and replaces it with something distinct, somehow foreign. It requires an understanding that we are in a continuous process of losing control. The transition from physician to patient is humbling. Like a large chunk of ice separating from an iceberg floating away, it is an inevitable reality. This I believe. Okay? Yeah. This I believe, that while I no longer pursue athletic dreams, I can find suitable substitutions. I believe that people will learn that my pervasive slowness, and I don't know if any of you here have Parkinson's. I'm not asking for it. I believe that there will be a time when people in line at the grocery store will be patient with me as I pull out my credit card with painstaking, frustrating slowness. The slowness of this disease is just horrendous and very complicated. I believe that despite these daily challenges, it is quite possible to continue with a meaningful existence. I believe we underestimate our abilities to cope. I find that developing a plan, which is becomes part of the daily routine, is helpful, also mandatory, and allows for structure of the day. My motto is begin to stay vertical. Hold on a minute. I'm not doing that. Okay. Okay. Well, we'll move on to Vicky, who needs no introduction. Okay, you there?
It gets to be my turn now. And what I'd like to do is read from Tom's, his book was recently, just came out in paperback. And there was an addendum written at the end of the book, and it basically chronicles what has happened to him since his book was published in 2008. One of the things that I think that Tom has not mentioned is that Tom's main disease is Lewy body dementia with Parkinson's. This is slightly different. It's not an Alzheimer's disease. It is a dementia that basically is easiest to describe as a switch on, a switch off. We never really know when the switch is going to be on and when the switch is going to be off. So it's often interesting. Anyhow, I just would like to read this portion of it. When Life in the Balance was first published in 2008, I expected I would get a strong response. I believed that I had an important story to tell, that my experience as a physician turned patient dealing with a complex disease would be helpful to others, and that I would likely hear from patients, caregivers, and family members confronting dementia, Parkinson's disease, and other life-altering illnesses. What I was not fully prepared for was the strength of the response that I got. So many people had the intense need, the burning desire to tell their own stories to someone who understood. As letters, emails, and phone calls poured in by the hundreds, I realized for that these people, I had become that someone. Too often the burden of illness and caregiving is borne silently. Prick the surface of that pent-up emotion, and it comes flooding out in torrents. This is a good thing, this release, and I'm gratified that so many readers feel safe enough to share their stories with me. It means I succeeded in my mission to tell the story of my disease from the inside out. At book signings and lectures, I would look out over the audience and almost invariably see at least one person in the audience with obvious signs of Parkinson's. In the question and answer sessions that followed, someone else would always stand up and say, "My mother has Parkinson's, my father has dementia," and tell a poignant story all their own. Sometimes it seemed that these book events were on the verge of becoming support group sessions, and that was a good thing. For many, the simple knowledge that they are not going it alone is therapeutic in and of itself. When I set out to write this book, I hadn't fully realized how validating it would be for those living through similarly difficult experience to have someone else put it in writing. It's as if you are also telling their story, and they are grateful and even relieved because someone has finally put into words what they have been feeling but not able to articulate. I also sensed in the response of the book a need on the part of patients and those around them not to be counted out. When you are losing control, and illness is all about losing control, there is a strong tendency to go horizontal, as I call it. Every day my battle is to stay vertical, to stay in the game, so to speak. By staying vertical is a joint effort by the patient and all whose lives intersect with his or hers to carry on with life, even when life is no longer normal. I saw this vividly when I was persuaded after much reluctance to attend a session I call Parkinson's Dancing, sponsored by the Jewish Family Services in Boston. The idea was to get Parkinson's patients and their spouses or significant others into a safe haven where they could do group exercise and then dance without self-consciousness or inhibition. My initial response was probably like that of many others. Why do I want to do this? But I was so surprised by the fun I had that I promptly signed up for 5 more sessions. Even in illness, there is much to be gained from exploring new things, even if you have to swallow your pride first. In the original edition of Life in the Balance, I shared my deep concern and fear about the progression of my disease. Though denial is a powerful defense against the unthinkable, Parkinson's and Lewy body dementia are progressive diseases. Though the rate of progression can vary from person to person, and patients can even plateau for stretches of time and maintain a status quo, there is no doubt that my clinical status has changed since publication of the first edition. My mental lapses, the sudden shutting down of my brain that causes me to lose my train of thought, struggle for words, or even go completely blank for a time, are more frequent. My handwriting has deteriorated so much that I spend as much time deciphering my notes as I do writing them. Sudden drops in blood pressure, also Parkinson's symptoms, have also become more common. These clinical changes have brought about some major alterations in my life. I dwelled at some length in this book on the issue of driving and the freedom it represents. I wrote of my determination to continue to drive to the handful of nearby places where I could, I thought, still drive safely. Since the book's publication, I have surrendered the car keys. Driving has become a major concern for my family, and many readers expressed some concern about it too. So I agreed to be tested at the Beth Israel Deaconess Hospital in Boston through their DriveWise program, which evaluates the driving capabilities of people with illnesses. I underwent 3 hours of cognitive testing, followed by road driving on 2 consecutive days in a specially equipped car with a driving instructor and 2 social workers. The car was the biggest thing you ever saw. Their recommendation was that I no longer drive. I agreed. The program helped me realize that driving was no longer prudent. In some ways, the dread of losing the car keys was worse than the event itself. I was fearful of losing my freedom until DriveWise made me realize that the chances of my hurting someone were simply too high. Now a retired policeman named Bill Griffin comes 4 days a week for a few hours a day to drive me to the coffee shop, to run errands, and to my beloved indoor cycling classes. Not driving is another small surrender, but with Bill's help, I can now go more places than I did when I was limiting myself to the close distances. There have been other major changes, too. Before the book's publication, I was still traveling by myself to California, for example, to see my daughter and her husband and 3 grandsons. No more. I get too disoriented to be able to manage an airport concourse on my own. Streets, trains, stations, airports, they have become too overwhelming for me to navigate alone. If I travel, I must have someone accompany me. I have acceded to the desires of Vicky, my adult daughters, Penelope and Sarah, when it comes to staying overnight in the house by myself. Though Sarah doesn't live far, she has children, and her motherly duties require her to stay at home. She's also a full-time equine vet. So when Vicky has to travel, the agreement is that we have someone stay the night with me. I don't think it's necessary, and I bristle at the infantilization, but life is full of compromises. Because it reduces the anxiety of my wife and daughters, I have accepted it, referring to my nighttime companion as my rent-a-friend. In short, my dependence on others has become much greater than it was when this book was first published. Yet, despite the discomforting trajectory of my illness, I fight hard every day to stay in the game, to remain vertical, and one of the things that keeps me vertical is this book. The experience has made an impact on my whole family. Vicki has joined me at most of the book talks and signings I have done, telling her own story with grace, emotion, and humor. The experience of going public with our tales has been as cathartic for her as it has been for me. We have connected with countless people, learning about their lives as they have learned about ours. All of us, my wife, my daughters, my extended family, and I have found life after publication of this book more uplifting and reassuring than we ever could have imagined. Personally, I have derived tremendous satisfaction from speaking to the groups of doctors, nurses, and readers who have come to bookstores, high schools, community centers, hospital auditoriums to hear me struggle through a presentation that is not terribly fluid. Audiences tolerate my pauses, my disjointed words and sentences, and my sometimes inaudible voice, because I think they understand and appreciate the enormous effort it takes. And there is another reason as well. Just by showing up, I am telling them that there is hope, that even with debilitating illness, life can be both precious and meaningful. And me, though I can no longer see patients, I get to be a doctor again. Sorry. Since that was published, we have had even more changes. Tom is now, his neurologist has basically recommended that he has a cane, and he has to wear a lifeline when he is alone in the house. The deal is he has to wear the lifeline because I still work full-time. I don't often make it home till 6, sometimes 6:30, and he takes an afternoon nap. And the lifeline has given us
7:15. Small problem.
7:15. Anyhow, no, I do. I'm a little bit better than that.
7:30. Yeah.
Anyhow, so that we reached a compromise, and there's a lot of compromises. We fortunately have a wonderful therapist that has been with Tom even during Tom's first wife's illness, and then I have someone, and the four of us meet and we work out these compromises so that Tom can retain as much independence as possible. And this has been the lifeline around his neck has been the way that he cannot have a full-time attendant. How long this will last, I don't know, but it's working for right now. The cane is a whole nother thing because he kind of swings it along. He's not using it. But it does help. He's taking lessons. He's only had one so far. But anyhow, so those are
the pain. Yeah. What were you just saying?
You were talking about the pain. We lose track every once in a while. Bear with us.
Pain.
The pain of what? Losing your independence?
Loss of control, having to make compromises every day, not being able to predict what the days are going to be like. All of that kind of coalesces and keeps us continuously in a state of flux. I get achy and and try to say, it's okay once or twice a month to have a meltdown. And I try to reduce crankiness as much as I can. It's difficult to do.
One of the things that I spoke about is this Parkinson's dance group that Tom has become very much involved in, and it meets once a week for 2 hours. They basically dance for roughly about an hour and 15 minutes or so, and then they have a group discussion. This has been probably one of the most beneficial aspects to this dance group. Tom has turned out to actually have taken over as leadership. I think mainly because he's the only physician in the group, so they figure that Tom is going to have all the answers. But it is an ad hoc therapy group, and everybody is at different stages. Tom is the only one that does have the Lewy body dementia component so far. We also have just recently become involved in a Lewy body dementia support group. This one is a lot harder for me as a caretaker because the first event we went to, which we hosted at our house, there were 12 couples. Every victim of Lewy body dementia, and I say victim because it is a really tough disease, was male. They all had postgraduate degrees, which was shocking to me. And they all had such a different story in terms of how the dementia had presented itself versus how the Parkinson component is. This is new. I'm just getting my feet wet in it. Tom is not sure that we want to go out in social situations because as I said, well, I get to look at Tom every day and see the struggles that he has. Do I want to be constantly seeing everybody else's struggles? So we're coming to grips for that. We were one of the first times we ever met a family with Lewy body dementia. The wife, we were at a Parkinson's event with Michael J. Fox, and the wife came up to me and introduced herself. She did not give me her name. She referred to herself as a caretaker and introduced her husband with a name. At that point, I was ready to run out the other side of the room and jump out the window because I started to be really concerned about my role in this, and was I going to lose my identity trying to help Tom continue with his identity. So there is, when you have a chronic debilitating disease such as this, you're weighing two different needs. And one of the reasons I continue to work is so that I do have my identity. Tom it is amazing what this book has done for him in terms of the people that have continually, we're 2 years out, who call him and come ask for times that they can come and sit and talk to him. Tom, on a one-to-one basis, is amazing. That he can convey a sense of calmness about how to approach this disease. What else would you like to say? We're always open to questions. We find that works really well for us.
So we decided Vicki asked the other day what changes since publication of the book, and there are significant changes, as I've already alluded to. We are in a state overall loss of control. This is associated with increased anxiety, both of which have increased significantly since the book publication. Caregivers now are in a state of sustained vigilance. Vicki is on 24/7, and that's an inevitable issue. But it puts her, as you can understand, in a very complicated psychodrama. We've had to hire someone like Rent-A-Friend as a personal assistant, and she's been extremely helpful in dealing with the day-to-day activities, making sure that I am vertical and not horizontal. The hiring of a driver for a period of time each week also gives me a sense of independence. The cane, I was really cranky about the cane. I mean, because I thought it really symbolized what's happening, and that we all have certain biases. That you see someone with a cane, and you wonder what's wrong with you.
But let me just interrupt for a second. The cane yesterday, when we got to the airport at, I think we got there around 5:40 in the morning, and the cane enabled us to go to the front of the line. I thought this was the best thing that had ever happened to us. We got handicapped. I mean, I don't know, but there we went, right to the front of the line. We got in, no problem. Everyone was nice to us. I found this the first time we went to a social event. It was like the waters parted. I mean, all of a sudden, people were paying attention. But it was nice. It was not anybody feeling necessarily sorry for us. It was just merely, oh, let me help you. And it made them feel better. So, again, Tom came home that night and told me I wasn't cognizant. I was not as, I wasn't paying enough attention to him. And I said, what are you kidding? My whole life was changed tonight. You know, and I just wouldn't let him get away with telling me that I didn't feel sorry enough for him because he had to take the cane out. It was great. We got taken to a private elevator. You know, it was terrific. There's a
listen. Time and listen, part of the equation. Acknowledge that hope is a piece of this puzzle, and hope, as I said in the book, is essentially mandatory. I mean, when I talk to patients about this disease, or these diseases, the type including ALS, they have to, the patient needs your support and your acknowledgement that we can manage these. I can't say to Mrs. Jones, you have an incurable disease. I do say that it's taking the time to listen and taking the time to be optimistic is extremely important. And I'm not saying that we minimize these things, but I have learned so much about taking care of patients from what has occurred. Now, I'm not formally taking care of patients. I don't have a Massachusetts license. I took care of all of those things. But I can sit and talk to people. And that was always the 4+ positive aspect of being a doc, was optimism, hope, coping. Being positive doesn't necessarily mean that you're talking down to the patient.
Tom's most recent appointment with his neurologist was one of the first times that Tom went in and really complained. I mean, I kind of sat there and didn't expect this, what was coming out. And his doctor, Dr. John Groden at Mass General, gave him such, he just sat there and looked at him, never looked at me, just looked at him and listened and let Tom go through this mini tirade about what was going on and paid attention and then said, okay, I think we can work around some of this. And we started to,
when in doubt, do something with the medication. the drugs. The drugs are bad. I mean, I was mentioning to Vicki a little while ago, you want me to take a pill. I tell you I take 8 to 10 pills a day. Take a pill. And I can't say that that pill is going to prolong the patient's life. So then why am I taking it? Well, I'm taking it because it's going to help me feel better. Now, invariably, the drugs for this disease make you feel worse for a period of time. And that it can be extremely cranky in reality.
But he listened and changed Tom's, cut back on his Sinemet, which was making most of the symptoms that Tom was complaining about were caused by the Sinemet. And he literally cut them back. We're now, taking half of what he had been taking. Is there a difference? There's a difference in terms of how Tom is feeling. He feels he has a little bit more control, that when he takes the Sinemet, it doesn't make him just go down first before he goes back up. So instead of adding more, for Tom it worked that he cut back. But the reason he got that, and we got a program, was because his doctor sat and listened to him. And I know in this day and age how really hard it is to have the time to listen to a patient who has a chronic neurological disease, because it's hard to listen to them. They're not as clear as you want them to be. But if the only thing that we've learned is that the doctors who do stop and listen to Tom, the better Tom does.
Sort of as a follow-up to that, as you may know, this afternoon there's also some talk about healthcare reform, how that's evolving and affecting the way we do our practices. And as a primary care physician, this very issue of the time that we can and need to spend with our patients with chronic disease is always being strained at by the needs to produce and see a lot of patients. And so one of the concepts is the team approach and the role of either social workers, nurse practitioners, mid-level providers, and so I was curious your thoughts on obviously the importance of the physician, which you were saying to listen to, but the role of the team in providing that service as well.
I think that's an incredibly important statement. And the frustration of being pressured by the system to behave or to see patients in a particular way is really profound. And you don't need to be a Rhodes Scholar to take care of people with these diseases. You could be an interested family member. It could be a co-worker. One of the things that I ask patients, does your phone ring less now? Why the phone ring less? And many of them are telling me now what's happening is that people who were friends of theirs or associates of theirs are no longer able to do that. And shucks, I just lost it.
I think he's talking about the team approach.
Okay.
is the best approach, but Tom has an incredible team. He has an incredible support that's behind him. I think part of it is, yes, we are lucky because Tom was a renowned cardiologist. He had a reputation. And so I think in the medical community, there is given a little extra time because of his stature. But I do think that we are also, I am a fierce advocate to make sure that Tom is listened to, that he's paid attention to, and that nobody forgets him. With a disease such as Parkinson's, people are afraid. They are afraid it's catching. Dementia, whoa, let's run as fast as we can. We don't want to be around it. But the best thing that for Tom is to be around people. He has not been rendered stupid. He merely has a disease that causes him to forget, to lose his place. And it is not something that is catching.
I call it the Leprosy Syndrome. That's what it reminded me of at first.
Tom, have you participated in any research, either diagnostic research or therapeutic research? And if so, what is your recommendation to patients?
I'm not sure I understand.
He has not participated in actually any formal research study. We have tried on several to try to get him into one. One was dealing with CoQ10 in the very beginning. But unfortunately, Tom didn't qualify. He's kind of past that stage. So no, he has not. If you take it from my point of view, I'd look at everything possible. And basically, I think that we have looked at just everything. I am constantly on the warpath. There was an article in the New York Times about a gentleman who has Parkinson's who basically could not move. You got him on a bicycle, he could bicycle for 10 miles. It was amazing, and it had been written up. So I immediately, said, all right, we're going to take that bicycle out of the garage. You're not going to just do a stationary bike. We're going to see if we can do it. We haven't done it yet, but we're going to,
I don't know if any of you noticed it, but over the last year in particular, exercise has assumed a lot of very positive, extremely accurate benefits. And I think that the number of the studies that are ongoing now about the benefits of exercise is going to deal with very high doses of exercise as part of an aggressive appropriation of resources that are going to be difficult in coming.
When he talks about exercise, Tom does some form of physical exercise every day. He does not get that opportunity to stop. And upon our first meeting with this Lewy body dementia group, there were several men that were not doing any form of exercise. And the difference between them and Tom, to me, I was blown away. I think you cannot count that out at all.
Well, we're an audience of physicians, so if anybody here has any good ideas for you, I would love them to speak up too. I'm a psychiatrist, and people that stutter, which in my early training was nervousness, it's not. It's a brain loop. And people who stutter who sing don't stutter. That's one of the ways they'll get it. So maybe when Tom dances, I wonder if his movement is different when he dances. I also wonder if Tom's got talent. But anyway.
He's got talent.
But is it any different when he's moving in a different sport? The kind of stuttering of the movement, is it any different?
I think his spinning, when he does a spinning program, and once he gets on that bike, he may not do it at the intensity that the rest of the class does it at, but he can do it all the way through for a whole 55-minute class. It does help that his class is at 8:30 in the morning, and the majority of participants are yummy mummies, and they love my husband.
Thank you very much.
Another suggestion, you mentioned that there was a family member who was an F1 vet.
Yes.
You mentioned that, anyway, you might consider riding in a therapeutic program to help balance, to help speed your reaction, smooth movements, think quicker, move quicker. All those things have been proven to be helpful, helped by special riding programs.
It would be nice. I think that would be a fun thing to do. The last time we tried it, we were at a friend's ranch out in Wyoming, and the anxiety that comes with Lewy body dementia really overtook kind of his comfort level, and we finally decided after about a half hour, 40 minutes, that it wasn't going to work, just because he was so anxious, which made everything a lot worse at that point.
Sure.
I have another comment. imaging have in your recovery? I know, with chronic diseases, a lot of people get very depressed, and you know that there's a downhill spiral because of the depression. So, do you believe anything like positive imagery or positive attitude, or even like The Secret or anything like that to help you in your day-to-day existence?
I think for Tom, I don't think it's a formal meditating or it is a formal, he's a positive person to begin with. Depression comes with these diseases, but because Tom is basically can always find the silver lining in most everything, that it is his natural, it's his natural bent to always, be much more.
The optimist does better than the pessimist.
So I think I wish that I could say that there was formal, but he does not. He has not done anything formal.
Heard of people doing it in a number of clinical scenarios, but nothing that I've done specifically.
You said something about the light bulb, and I'm not familiar with that. Can you tell me a little about it?
The lifeline is merely it's a thing that goes around your neck, and if he falls, because unfortunately Tom is falling fairly often, although I don't know, he's figured out how to fall with never his head touching the ground. His body is taking a bit of a beating, but if he falls and no one is there, he can press this button, and we have monitors in the house. Someone will then come online and speak to him and determine whether they need to call the ambulance, but if not, they will merely contact me. We have a list of 4 people that are on the contact list. Tom also has been unable, he can no longer manage a cell phone, but one of his daughters found a cell phone that has merely 4 numbers.
It looks like a tinker toy. But for someone as technologically now inept, I used to be pretty good before. There's the old Tom, but the new Tom is frustrating. And I haven't been able to figure out how the cell phones work. So one of my daughters said, we're going to make it as simple as possible. So this little puppy, you can only take 4
numbers.
4 numbers. 1, 2, 3, 4, that's it. You can get incoming, but you can't do outgoing other than 4. So it's generally is Vicky and my daughters.
His assistant, and it can go 911. So
had to swallow my little bit of ego with this thing.
But this enables Tom to still have independence, so that if he wants to go out in the afternoon and walk from our house to the local Starbucks, Tom always likes to have a destination so that he knows he's going to get a treat at the end of a walk. So that this enables him to be able to have it, and he can press. Even if he doesn't get my number, if he gets anybody's number, it will, get to somebody quickly, and without him having to worry about it. But it has made, it's our compromise so that he can go out on a beautiful sunny afternoon by himself, to be able to do that.
Yes,
Dr. Graboys, you had mentioned that many of the things that are most difficult are changes in lifestyle that have been required by your disease. And in challenges today and many chronic diseases, it's a matter of having to change lifestyle, whether it's diabetes, obesity, chronic neurologic disease. And certainly as a cardiologist, you've had recommendations about exercise and changing lifestyle. You have, I'm interested in your reluctance to make those lifestyle changes with your disease. Is there any advice that you have for physicians about how we can do a better job of telling people, convincing people, motivating people to change lifestyle?
It's a long journey to do that, but I think we have tried to be aggressively as possible with exercise, aggressively as possible with psychological stress, integration of the family unit, not make assumptions that just because you've been diagnosed with something, that don't make assumptions that it's not worthwhile. It's very worthwhile, and I think that's one area that we always need help with.
My suggestion is to not go for always the big picture, but to go start with the baby steps. Tom always talked with his patients about kind of taking the smaller steps first, the ones that could be most meaningful. And there's a lot of compromise, I think, that has to be involved. I think that involving the family has been huge for us, and I think it's huge. Tom, when he was a practicing physician, always encouraged the patient to come in with a family member, wife, husband, somebody who could not only be an advocate but could also have that extra pair of ears, and that has served us really, really well, because if I'm not there, one of his daughters are, or one of my children can step in. But it is the smaller steps first, and it's not bombarding this patient who is so overwhelmed with this initial diagnosis that they can see nothing but doom and gloom, and it's finding smaller things that can give a modicum of hope. And it's not easy. As I say, and with Tom and myself, it is a never-ending battle of compromising how much I'm going to let him do that will make me feel comfortable, because sometimes he forgets that this is a two-man disease. I have this level that I am always worried. But I find that the little steps, patience, you need a lot of patience. And that sense of humor.
Tell them about how you...
Go ahead.
Would you talk a little bit about when this disease first presented itself? Was there a time when other people noticed something was wrong before you did?
Oh, yeah.
How did you deal with that?
It's a classic experience. We say that in the book it's about 5 years, in the mid-50s, that this was the onset of the disease. I don't think that's true. I think,
In the mid-90s.
I don't think that's true. Shucks. It's a key point, too. And it's
Ask your question again, could you?
Well, was there a time when other people realized that you had something that you didn't?
Yes. It manifested in a number of ways. One was doing procedures at the hospital. I noticed it, and one of my friends noticed it, but just said, well, Tom is, I'm just a little fatigued, and that's it. I just need to take a few days off. I did everything I could to deny its existence. In Boston medicine, which is very aggressive and competitive, if you show any of your vulnerability, it comes back to haunt you. And that's been a real issue.
But one of the turning points was when Tom was walking into the Brigham one day, and a neurologist yelled across the parking lot, "Tom, who's treating your Parkinson's?" And it literally, he came home that night, and he knew that he could no longer hide this. When Tom and I got married, within 3 months of us living together, I knew something was not right. He could not set a table. He could not figure out the forks and the knives. I didn't quite understand this. Before we were married, I saw a slight tremor. Tom dismissed it as being, it's an essential tremor, I'm tired, And so I trusted him. He was the doctor. He was, what was I, an interior designer who didn't know anything. But within 3 months, I realized something was wrong. We went to an event with doctors that he had not seen for a long period of time. they approached me afterwards. So by the end of December, I had doctors talking to me. By the end of January, we had our first appointment with a neurologist. And then for the next year, Tom lived in denial. He knew it was Parkinson's. He knew it was something perhaps cognitive. But he did everything in his power to fight this. And the overwhelming fatigue of the battle of hiding something like this nearly did him in. It nearly did me in. But that one doctor who screamed across the parking lot, which, when I think about it now, was really not too smart, but it would have been nice if he maybe came up and patted him on the shoulder. But even friends of mine at a dinner party said, does Tom have Parkinson's? So.
I had a situation that's a little different. Just from my tears, I feel like you'll know how I feel for you. Was a pediatrician and still am, but nobody will come and see me. I'm just teasing. Anyway, I had a brain injury about 5 years ago, and I've gradually lost my memory really tremendously, and I've had to quit practice because of it. But I think what I want to do is let you know how much anxiety I feel just when you're up there talking, because I'm almost afraid to talk to anybody here. And I come to these meetings, and yet I enjoy coming, because I have to tell so many people that I can't remember, and it gets old. It's so old when you have to say that to somebody. I appreciate people that are so patient. My wife's home right now. I had wanted her to come, but I think she's worn out, and I don't know how you did it. Because almost everything I say to her is I can't remember. And she'll say, "Oh, Gil, surely you remember that." And then I feel even more stupid or anxious. So if anybody here can understand that without having this problem, I think you have a great gift, and my wife has a great gift in taking care of me. I just appreciate knowing what you're going through, not the fact that you're going through it, but knowing what you're going through, because you've taught me a lot today. And I appreciate it. Thank you.
Thank you. How are we doing?
One other question. As a family practitioner, I think about Lewy body dementia as having very vivid dreams. I was just curious. I haven't read actually what those are actually like.
REM sleep, which Vicki can tell you.
Right now we seem to be, knock on wood, in a good phase without a lot of REM sleep. That sometimes is often helped with medication, but Tom has been able to not take specific medication for it. REM sleep is probably one of the earliest symptoms of Lewy body dementia that I noticed, and there had been an article in the New York Times magazine section, I don't know, must have been 10 years ago, or when I had met Tom and I held on to. They are wild. They are violent, and they are violent in nature. Tom can sometimes, if we wake him up when he's having them, he can quickly tell me something, but most of the time I cannot get him awake enough. We do sleep. I put a pillow sometimes down the center of the bed so that I can protect myself. Sometimes I have to literally throw my body on top of him to make sure that I am safe. The last time he had one, for some reason I decided to go after his mouth because he was making so much noise. And I, almost got bitten. But we're lucky we don't have them. They are very violent and they are very disturbing. When Tom has them, he has trouble coming back from them because they are so disturbing in nature, but he can't always put a picture to what they are. But they're from our experience, they are violent in nature. No.
Very good. Well, thank you all very much. We
Thank
really
you.
appreciate this. Great job. You once again.
Thank you very much. That was fantastic. Again, thank you for both Tom and Vicki coming to share that story with us today.